Good evening and welcome to this BAUS webinar on urology in the COVID era. This is hosted by the Royal College of Surgeons of Edinburgh, for which we're very grateful. Next slide, please. As we all know, COVID-19 has been a challenge of significant magnitude, and as a result, there's a lot of information, both good and bad, out there. Whilst in the UK, there's a lot of general advice from government sources, we felt that it should be BAUS who produces specific urological advice, and so we set about providing this on several topics. Firstly, in mid-March, we published on the BAUS website some general information for our patients, and this included a frequently answered question drop-down menu. At the same time, we produced a prioritization document for our members, stratifying all urological procedures into 4 stages. Stage 1 being the first to be cancelled through to stage 4, emergencies not to be cancelled. Towards the end of March, we realised there was an issue with PPE recommendations and published our guidance on that. Next slide, please. Before the end of the month, a lot of laparoscopic general surgery had been stopped due to the attendant risks, and we constructed a review of the current literature to see what was known about this and urological surgery. We published this just before the end of March. Counselling and consent was another area of increased complexity due to the added twin threats of COVID-19 against the possible risk of disease progression during any delay in treatment. Some excellent initial work by Rana Zachary at Guy's and St Thomas's was modified by trustees, and we published this in mid-April. As the situation has moved on now, we've mostly seen the first peak of infection has passed, and our thoughts are turning towards the reintroduction of non-emergency urological surgery and activity, and how we might safely organise this. We therefore, in early May, produced an overall document and more specific section advice, which is the main subject of this evening's discussion. I should point out that these guidelines are merely that, they're just guidelines, and it is recognised by all there is huge regional variations in capacity and what is and what isn't possible. Next slide, please. BAUS also liaises closely via the FSA and all the surgical colleagues with the government and the NHS, so it's not as if we're singing in isolation. As a marker of how useful these guidance documents might be, we've had almost 4,000 web page visitors on the COVID topics by patients and over 7,000 by our members since this advice was posted in mid-March. I'm indebted to all those, including your panellists tonight, who have worked very hard to construct these documents. Next slide, please. So this evening, we should have about an hour or so in the following format. Our stellar panel in front of you is made up of the section chairs, Madge, Darren, Sheila and Ben, who will in turn do a small salient presentation on the recovery document, and then there will be time for questions in general. Both those questions are already submitted and those typed to us, and you can send them live during the meeting. Next slide, please. We've got over 570 registrants tonight, so it's unlikely they're going to be answering every question that everybody poses. However, if there's a specific question you want answering, please just type it with your identifying name, which will be unknown to us, and the College of Surgeons will pass our answer on to you in the next few days. If this evening proves useful, we're going to have further meetings guided by your feedback, so please feedback and help to make these as useful as possible to you all. I'm indebted to the Royal College of Surgeons for hosting this webinar, and particularly Ryan Lowry from the Education Department for his technical help, and also our members Mike Palmer and Mary Brown who conceived this idea, and especially for all of you to joining us. So without further ado, we're going to hand over to the first presenter, Mr. Madge Shabir. Thank you.
Thank you very much. Can I have the next slide, please? So in andrology, we're very fortunate in many ways that the conditions we look after don't pose any risk to life, but they can significantly impact on the quality of life. Now, in the initial phase of the recovery, andrology is going to take a lower priority than other conditions. And as a consequence, there are going to be more significant delays to our patients, especially if there are any further secondary spikes in the condition. So in this particular phase, it's very important that we minimize the risk of the underlying clinical conditions getting worse while our patients are awaiting definitive treatment. It's important that our patients are kept well informed of the need to change their treatment timelines and they have realistic expectations about what's going to happen. But we must also provide them with support and easy access to those remote services that we're setting up in case they have a change in their condition while they're waiting on those waiting lists. And it's absolutely paramount that patients don't get lost on this waiting list system because there is a very high risk of that happening given all the rapid changes in the admins up and down the country. Next slide, please. Now, over the next couple of slides, we're going to be talking about new categories for determining surgery and when to do cases when theatres reopen again. But talking about the kind of general principles about recommendations for surgery, same things that we're saying here are attributable to all the different sections. Wherever possible, alternatives to GA should be considered. Temporizing procedures may be more appropriate in this timescale rather than the things that we would do naturally, such as urethroplasty, rather than being able to do that until it can be safely offered. Perhaps a urethral dilatation and CISE may be a better option. The treatment categories we're going to talk about are based by the condition, but it's not just the condition that you have to take into account, it's also the patient in front of you, and we have to consider their age, their comorbidities, the risk factors, and other things when deciding on the final time for treatment. That decision about the treatment category is not static, it's fluid. And if there is a change in their condition over the period of time that they're waiting, we may need to reprioritize them. But it is important that all patients are aware about any potential risks as it becomes more evident about surgery at the time of COVID, both in the operative and perioperative period. Next slide, please. So we're not, as you've heard already, we're not going to be talking about the emergency cases, those which are categorized as NHS 1A and 1B, those listed here, which are the same category as before, and were managed in the same way as critically time-sensitive and urgent cases on call. New slide, please. What we're going to be focusing on in each of the sections will separate their things into the high priority, intermediate priority, and low priority cases for elective and semi-elective cases. In andrology, we have a lower proportion of high priority cases. What we're talking about here is things which are clinically urgent and time sensitive, such as the things which are mentioned here. The timescale we're talking about here is ideally within 4 weeks, but that is a proviso according to what the local, regional, and national pressures may be. And that may be relating to the theatre staff availability, theatre availability, other backlogs and competitions between other specialities, as well as within urology as well. And so it's, again, something to be used as a guidance, not as a dictum. Next slide, please. The intermediate priority is for categories of patients and operations which are clinically important with significant impacts on activities of daily living, as those listed here. Now, they would ideally be treated within 3 months, but again, that same proviso of that timeline exists. Next slide, please. The vast majority of andrological procedures are going to fall into this lower tier category and lower priority, and because of that, we've separated it within our section into 2 different groups. The first tier are the conditions which don't affect day-to-day living, but may have an element of time sensitivity, and the other ones are the ones which have no time sensitivity to them. A classical example of something which may be slightly time sensitive, but not affecting day-to-day life is the management of surgical sperm retrieval in infertile couples, where there's an element of time sensitivity based on the female partner, according to their age and ovarian reserve. And that's very much in keeping with other national guidelines, such as the British Fertility Society's excellent guidelines on restarting assisted conception. Next slide, please. The lowest tier of all is what's going to be the mainstay of penoscrotal routine surgery, which is conditions which don't affect day-to-day life and are not so time sensitive. It will include things such as Peyronie surgery and penile implant surgery and more routine surgical sperm retrieval. And again, the timelines used here are sort of guidance, as long as there is no risk of clinical harm to the patient if their treatment is delayed for a longer period of time. Next slide, please. As well as reconfiguring things in the inpatient and operative setting, there's also focus on the outpatient setting as well, where reconfiguration of services is aimed at trying to minimize hospital visits and the burden on the NHS overall. Whereas ordinarily we would think about doing face-to-face as our default setting for all consultations, this should become something we use only when we need to do a physical examination as an essential. And wherever possible, we need to recategorize things into video and telephone consultation, as I'm sure most people are already doing. In andrology, that does pose extra problems. You know, we're dealing with a sensitive part of the body. It's not somewhere they can just pose their camera to, but we need to think about sensible ways of getting patient-generated digital photos sent in that can be looked at in a safe and effective way that is in keeping with the local IT and governance structures of all the different hospitals. And everyone has to look at a system that they can put in place that's safe and robust and one that patients are comfortable with. Next slide, please. So going further with this, we're going to be helping to develop new guidance and protocols for the treatment and triage of different andrological conditions as a section to try to help provide some guidance on patient pathways that aiming and trying to rationalize patients' visits to the outpatient department to try to further reduce the burden of andrology to hospital visits and urological services overall. Next slide. just remains for me to thank all of my committee members who have come together fantastically well in a very short period of time and helped provide this guidance as a whole. Thank you very much.
Thank you very much indeed, Maz. That was a very good overview. And next, we have Darren, who's going to tell us all about the endourological prioritization and recovery document.
Duncan, thank you very much. So my 5 slides with one little cheater there by putting the official document that was in the overarching summary. And then what I've done in the next few slides is to expand on that slightly, including the need to sub-stratify within each of the priority groups. Next slide. So this is the high priority, due in less than 4 weeks, ideally. I think we have to remain very vigilant to the fact that we are not in an ideal world yet, and that this is also going to be a phased process. As Madge has already said, the emergency work, the priority 1A and 1B by the NHS documents, that has already been continuing to some extent, and somehow how we've all managed that in our different units. So this is the elective high priority work. And the way that this slide is laid out, this is all about obstruction and risk of infection and loss of kidney function, not the emergency cases of the obstructed infected kidney, but the more urgent elective ones. I've grouped the stone work first, so most of this is of course going to be ureteroscopic. You can see there that there's the first mention for some time of percutaneous stone surgery. It'll be interesting how that comes up in the questions about whether people have been doing sort of slightly more risky procedures, if you like. And the caveat in the comments is that this is for patients who've got a risk of sepsis or are losing renal function with a big stone. Thus far, certainly at UCH, we've kept those very much in reserve. Beginning to get back into the diagnostic for upper tract. I did one of these on my list today. And then the bottom 4 is the obstruction, and in part of our role in support of our oncological colleagues with chemotherapy. And we're going to see more, of course, of overdue stent changes. All of the patients that we've put on hold for the last couple of months are now coming around to fall into this higher priority group. Next slide. Oranges and greens for lesser degree of priority. So the intermediate, this is the NHS level 3, so within 3 months, low priority, which is a slightly emotive term. I can't imagine any of the patients who fall into this group will regard their situation as being low priority, but it's ones that can be reasonably and safely deferred for about 3 months. So this is more of the elective work, so symptoms rather than complications. We've included ureterorhinoscopy for the asymptomatic stone, but where if it were to grow, it would make the procedure more complex. I think there'll be not unreasonably a degree of debate about that. And then we've also included some of the bladder outlet obstruction work. Next slide. Of course, what the luminal endourologist really likes is detail, and a broad number of our patients fall into that high priority category 2, but we're going to need to subdivide those, and this does it by scale. So we would probably prioritize abnormal renal function over the issues of having a stent. In turn, stent or nephrostomy, more important than uncontrolled pain. And then at the bottom, the stone that's unlikely to pass. And as Madge has already said, it's all about alternatives, perhaps less GA work, maybe spinals, perhaps a resurgence for shockwave lithotripsy. Next slide. This is to help with those patients who've got oncological obstruction. Do they need their nephrostomy or stent changing sooner rather or later? Can they wait? And certainly one of the things that we've done is we've looked with even more scrutiny at their staging follow-up CT images to look, does the stent look reasonable, and therefore is it fair to defer them? And on the flip side, again, has already been said, it's not just about the diagnosis that we're treating, it's about the whole of the rest of the patient. And clearly those who are higher risk have got more to lose and less to gain. And it may well be reasonable to keep these patients into a lower category. Next slide. If you thought that it was difficult before, it's going to be even more difficult now. Cancelling everything was, of course, a nightmare for us all. It was a nightmare for the patients, but you only had to do it once. It was rapid, it was certainly achievable, and in fact, working all together with our combined purpose, we actually did it. Reintroduction is going to be more difficult. It's not going to be as quick as any of us would like, and working out which patients go into which group, even within our own speciality, is going to be a challenge. So we need to stay aligned and to remember that we're all still in it together. On the right, the Endourology Committee, there are a few other people whose photographs are not in there, but magnificent help from them. And on the left-hand side, Steve Gordon, who came up with this idea of using this as an opportunity to work differently and to incorporate perhaps network referrals for shockwave lithotripsy. And hopefully that's something that we'll see more of in the weeks ahead. Thank you.
Thanks, Darren. That was fantastic and very succinct and concise. So next up, we have Sheila to tell us all about female and functional urology.
Thanks very much, Duncan. So I'm Sheila Reid. I'm the chair of Female Urology and Urodynamics. Next slide, please. So transition to the new normal for FNUU. Firstly, already mentioned but some of the other sections, but telephone and video consultations have been a huge success in our speciality. I think it blends itself extremely well to this, and I hope that's going to continue in the future, along with appropriate face-to-face consults. All of our elective procedures have been cancelled over COVID, appropriately so, but specifically intravesical botulinum toxin, intravesical treatments for bladder pain, urodynamics. We need to plan for reintroduction of these procedures. Surgically, FNUU have got very few cases which we count as level 2, but there are some, and I'm going to speak about them. And just lastly, I just want to make a point that FNUU deals with a lot of patients that have got functional bladder disorders, a lot of pain disorders, and I think during a time where we've had to stop all input to these patients, it's a perfect time to reevaluate how effective our treatments are for these patients and make a proper plan for how they should be introduced. Next slide, please. So surgical prioritization, the high priority category, those are the level 2 priority group. In that group for FNUU are eroded or infected devices that cause significant pain or sepsis, ureteric obstruction where nephrostomy or stent is not safe, so that's like the endourological section, but obviously for the strictures. Bladder stones to avoid catheter blockages leading to life-threatening urinary tract infection or autonomic dysreflexia, and that's specifically in the spinally injured population in the neurourological section. Surgical treatment of urinary tract fistula causing urosepsis or delaying cancer treatment, or surgical treatment of patients intolerant of catheters that don't otherwise have bladder access, and that very much refers to the patients like the Mitrofanoff patients or those that don't have urethral access. Next slide, please. In the intermediate priority group, that is level 3, are suprapubic catheter insertion in patients who've got urethral catheters that are causing urethral damage, the bladder stones in the neuropathic and symptomatic patients, with the psychovaginal fistula repair, removing eroded devices or implants, symptomatic urethral diverticulum, and injection of botulinum toxin in the neuropathic high-pressure bladders. Next slide, please. And then in the low priority group, that's the NHS level 4, we basically have everything else, which is the vast majority of our surgery. So it's all of our stress incontinence surgery, all of our overactive bladder detrusor overactivity surgical procedures, including Botox in the non-high pressure bladder groups, sacral neuromodulation, and all of the major bladder reconstruction. Next slide, please. As for reintroducing procedures, obviously this is going to be a very local thing when hospitals are ready to introduce elective procedures, but we would recommend starting with those face-to-face outpatient consults where you can't make a decision without assessing patients' urine, bladder emptying, or examining the patient. For those patients who need to learn intermittent catheters to become catheter-free, botulinum toxin injections in lower risk patients, and that is lower risk with regards to COVID, who have significant symptoms who are already able to perform intermittent catheters. And then intravesical treatments for bladder pain, again in lower risk patients, although where possible, patients should be instructed for self-administration or installations in the community. Next slide, please. So this is our table that we've produced, and we very much stratified our patients into higher risk for COVID, which are those patients who are shielding, or the older age group, or the lower risk patients. And this is where the telephone consult comes into its own. Patients can have discussions on to whether it's appropriate to bring them up. Our procedures are very much quality of life, except for the handful of urgent stuff. Patients need to decide with their clinicians whether it's appropriate to bring them up and start treatment. Next slide, please. Just my final slide, just on urodynamics, because we've got asked a lot of questions about this. We don't feel it's an initial priority procedure. It shouldn't be put online as the first thing, and should only proceed where it's safe and appropriate capacity in the hospital. There are going to be challenges with urodynamics. There's often a lot of people in the room. There's quite intimate insertions of lines, and also the procedures are done often to decide on surgery. This is elective surgery, which you may not be able to offer the patient at the moment anyway. But very importantly, there are some exceptions to this, particularly in the spinally injured population, and clinicians have to be able to request these procedures if they feel it's clinically appropriate. Next slide, please. And just lastly, to thank the FNUU committee for all their hard work in putting together these guidelines. Thank you.
Thanks so much, Sheila. That's a very good overview, and indeed, your committee, all the committees have worked really hard with a very short time frame. So next we turn on to oncology and Ben Challicum, who's going to tell us all about the new or the modified guidance in urological oncology. Ben.
Duncan, thank you very much. I hope you can all hear me. I'm very grateful to Royal College of Surgeons of Edinburgh for putting this on, and in celebration I've got out my Royal College of Surgeons of Edinburgh tie. Not wearing many ties nowadays. So next slide, please. I'd like to also just up front thank the whole committee, particularly Krishna Narahari, our secretary, and everyone who's really mucked in to come up with these guidelines. For the operating services now, in its revised format that was put up last week, many of you will be familiar with this. We have quite a lot of oncology that is level 2, which includes cystectomy for muscle invasive disease, high risk TURBT, large nephrectomies and nephroureterectomies, orchidectomies, slightly rarer cases of salvage RPLND, which are very time dependent. All the penile cancer services are still up and running, and prostate biopsies, hopefully under local anaesthetic in men who really need them. And then the level 3, which of course now people who were being prioritised at the end of March, when many centres may have started shutting down, they may have waited 4 weeks then. Towards the end of May, of course, they will have waited 3 months, so they're now clicking up and becoming, in many ways, level 2, are the radical prostatectomies. My bias, excuse me for putting in robotic, but anyhow, where you do radical prostatectomy, cystectomy for often non-muscle invasive disease, TURBTs, low-risk NUs, and all the rest of the things that you can see there, with a view to starting up again brachytherapy, channel TURPs, and that included with that is stents, which Darren's pointed out, linked to enable other treatments, prostate biopsies in a wider group of men, and also the interventional radiology and ablative procedures. Next slide, please. So I'm grateful we had to start somewhere. We came up, I sat down with my colleagues, Paul Cathcart and Christian Brown. We came up with some principles, which we then rolled out. I put in front of the committee. We thought that this is important for these areas, which are not just about the surgery, it's also about the whole management of these cancers at the current time. So important to continue doing as much as you can for as long as you can, and getting back to doing that as early as you can. But we realized that we needed to minimize outpatients, minimize the risk of missing significant cancers and of disease progression. Importantly, I think minimizing the risk of doing unnecessary things that could generate A&E attendances, sepsis, and general anesthesia unless absolutely required. And linked to that was avoiding prostate biopsy in men with significant frailty and comorbidity. We wanted to try and reduce radiology imaging services as much as possible, although now they may be more freed up than originally. And importantly, also to reduce the amount of chemotherapy and immune therapy at the time when we really thought this might be a complete no-go, which is again coming back on slightly. A point that was also importantly made was that a lot of patients are scared at the moment, and they may DNA. And whereas a DNA often is, our response to that is to discharge somebody, obviously in an oncological patient, we need to have a method. Each centre, I would really really urged to have a method of tracking those patients who are DNAing and working out really what is going on, and phoning those patients and having a way of really following those up. So next slide, please. So we have put out a guidance document on all of the 5 urological cancers, and of course done the penile and testis in conjunction with the sections of andrology. And these are really in red, the changes in the updated documents. I think many of you have looked at these, and I've taken feedback from everybody who's emailed me. In the bladder cancer side of things, it was really to bring back in BCG. I think at first we thought it was likely to be linked to immunosuppression. That appears to be not the case from the reports around the country, and of course trials looking at BCG being a protective factor. So we've changed the wording there, that perhaps we just want to do it to reduce exposure to patients and footfall rather than any immunological reasons. The next slide, please. I'm thankful to Professor John Kelly at UCH, who's done, I think, 25, 30 cystectomies in the last couple of months, for really highlighting that initially we thought cystectomy was just going to be too dangerous to do, but actually he's audited all of his. They've done very well with a period of isolation, and linked to that and reports from other centres, we brought radical cystectomy for those patients who need it, who are sensible and low enough comorbidity to bring that back in, and also brought in, thank you to Professor Nick James, some issues with potential radiotherapy and a 5-FU mitomycin up front. Next slide, please. The kidney cancer, I've had lots of input from Ravi Barod at Royal Free, who's been very grateful for that. And this is just the updated areas this week, is that we should perhaps now not shy away from staging all patients with kidney cancer, which we had said originally. T1A and T1B tumours can be treated if appropriate. We can do renal biopsies, we'd recommend that if needed. And ablative therapies are back on track. And even cytoreductive nephrectomy, of course, in younger low morbidity patients. But if somebody was perhaps had a small equivocal lesion or a small lung metastasis, that wouldn't be unreasonable to get on and do those patients now. Next slide, please. Of course, most of the feedback had been around the prostate cancer guidance, because of course it takes up such a large part of our work, both diagnostically and in treatment. And again, continuing with the current diagnostics and treatment protocols, I think, as long as possible. Many of us are seeing far fewer men coming through, and it's nice for them not to be stuck halfway along the diagnostic process, which I think is really stressful for men in that situation. Radiotherapy capacity may be reduced, and of course, the need for hormones may be longer than normal. Many centres are now returning to prostate biopsy. Luke Stroman, one of the London trainees, has done a poll on that, and I've got feedback from 100 centres, and I think the majority of those are doing some elements of prostate biopsy. For me personally, I'm biased towards trying to do that in a transperineal route, because I think the risk of sepsis at the current time is not something we should do unless there is no other option in your centre. MRI scanning, I think we're back on track with. Brachytherapy under spinal, and I've had feedback throughout the London region that many centres are now starting back with radical prostatectomy in higher risk cases with low comorbidity without lymph node dissections. Also grateful to Professor Nick James, for getting across that enzalutamide has now been sanctioned by NHS England as a treatment instead of docetaxel. And this is really important for the men presenting with metastatic disease put on hormones, that this can be used up front. Next slide, please. Finally, last couple of slides, I'm just very grateful. This was shared with me over the weekend. Sinan Kaduri and Vero Kazivisvanathan, who you will know well from the Identify study, they've asked me, they said it's okay for me to share this with you, that they've had an invited paper to the Lancet looking at really the maths of if we were to cut back on flexible cystoscopy and only do ultrasounds or CT for visible and non-visible hematuria, how that would impact. And interestingly here, this is for the visible hematuria. Basically, if you have an ultrasound scan and plus or minus cytology for a younger patient, you can be very reassured. You're not missing very many. If you have an ultrasound scan for 35 to 60 for visible hematuria, and that is fine, and your cytology is fine, you're only missing 3.4%. So then you may decide to defer those flexies down the line. If you're over 60 and you have a CT, again, negative CT, 10%. So it's about how we look at risk. And I think at the moment we're not saying what is the right thing to do. We're just allowing clinicians, perhaps with this information, to be able to discuss this risk with their patients. And then next slide, please, last slide, is the non-visible hematuria slide. And this is quite important, I think, that if you are under 50 in the current pandemic and you come in and you have a negative ultrasound scan, that you can be very reassured that you've not got something going on, and you almost certainly don't need a flexible cystoscopy for those patients. And some centres may not be seeing these patients with non-visible up front now, but I think they're going to come back. We may want to use this. For the 50 to 69, again, if you don't do a flexible cystoscopy, we're missing 1.5% of patients. And this, I think the data set is about 11,000 patients from all around the world. And then over 70, again, you're missing 2.9% of patients if you have a negative CT they used in that one, but I would think it would be similar numbers for ultrasound. So just allowing people to take those numbers on board when they're discussing things with their patients. But thank you very much. That's our slide set. Thank you, Duncan.
Thank you very much, Ben, and thank you to all the panel for keeping to time and to provide that excellent overview. So we had some pre-submitted questions, and we've got lots of questions flooding in, which we're trying to grade and answer and sort of put into some sort of order as we speak. I'm going to start off first with just a general question, which was submitted a couple of days ago. And Darren, I'd like you to answer this if at all possible. So during endoscopic surgery, is there any chance of contamination through urine from a COVID positive patient?
So as far as I have understood, and there seems now less of a wave of paper after paper after paper with 4 or 5 patients or even more published in the New England Journal telling us about things. But what I gleaned from the ones that I saw is that there was pretty much no COVID-19 in the urine. Previous coronaviruses have been seen in the urine, but this one not. So I think that if you're taking all of the other precautions, in particular, if you've tested the patient, we're certainly doing that. It has its own implications. But if the patient has been tested and is negative, particularly now as the community levels are reducing, the likely amount in the urine is going to be very small, and you've got other protection, and you're not creating aerosol of urine when you operate. Then I think that you can be pretty reassured that the risk from that is negligible.
Okay, thanks. How are you testing your patients, Darren?
So we're now bringing them in for swabs. We're getting them to isolate for a week or so before surgery. They have the swab 48 hours before. When we first introduced it, because of course we've all been learning everything as we've gone along, we brought them into the hospital to keep them there. But that didn't work because actually one of the patients who was on my list swabbed positive, and that result came back on the Sunday night, and he was in the same bay as another patient who'd swabbed negative. So that's a proper dilemma. So in fact, what we're now doing is we're letting them go home. They can arrive for their swabs on public transport if they can get on it. And then they have to go home by private vehicle, and they come back to the hospital having isolated strictly for those 48 hours, and then have their surgery. In my case, it's on a Monday. The difficulty with this is picking up the results because they come back on a Sunday night, which is not absolutely ideal, and certainly doesn't give you a great deal of room for manoeuvre as theatre time becomes more precious. Really, we certainly don't want to lose out on operating on somebody else if somebody is swab positive. So I think there's quite a bit of work to do in this.
Yeah, thanks for that. On a similar vein, Ben, if I can turn to you, there's been a lot of questions, multiple questions on transrectal ultrasound and biopsy. I'll just read one out particularly. In Wales, we do not have the facility to perform transperineal biopsies, and therefore, for high-risk patients, we've been performing trust biopsies. There is evidence that the coronavirus can be present in feces. I think it's about 30%, isn't it? And with this in mind, should the procedure be designated red for PPE? So how do you advise that? Do you test people beforehand, and what PPE do you use if you do trusses? What's the advice? You're muted, Ben, at the moment.
Sorry, wouldn't let me unmute. So the facilities to do transperineal biopsy are generally the same setup for a transrectal biopsy, but you do need one of these two little gizmos on the market. So I think that there are facilities, you just need to get hold of this equipment, and of course there is an element of being trained, but that's difficult to do in the middle of a pandemic. We are wearing, Rick Popert's been pushing this heavily in our unit. He's actually got had an audit of the first 4 list, which was about 20 patients of high risk patients that he did with PIRAD 5 lesions. And he's had that accepted as a comment to the BJUI, and we have found that that has been safe with a questionnaire and everybody wearing an FP3 mask. It's not a big data set. They are not self-isolating, and we're not treating it as an aerosol generating procedure. It's difficult, isn't it? There's no guidance really on whether that is aerosol generating or not. I don't think I want to be up close to the perineum without a proper mask on though.
I think also as well, the literature's coming out that it's a length of exposure, isn't it? And I think if you're doing a flexible cystoscopy, you're there for a few seconds. But if you're doing a transperineal or a transrectal ultrasound, you're probably there the best part of 10, 15 minutes. And that might be more of an effect, to be honest.
No, absolutely.
Okay, all right. Just around the panels, anybody getting are all flexible cystoscopies and truss biopsies being swabbed beforehand? No, we certainly don't do that. No. Okay, so there doesn't seem to be consensus on that. Okay, moving on to some other questions. I think this is quite a good question. We're just moving a little bit around a bit. Sheila, I'd like to ask you this one actually. So we've got a question from the BSOT current chair, Sot Tolafari. He said, given the current sort of chance of a second peak, should trainees be operating on COVID positive patients?
I think that's a really good question, actually, and there's an absolute answer to that. There's a lot of training implications here during the COVID period of time. The trainees are not seeing the patients, they're not getting into theatre. The operations that are going on are high risk, difficult operations that are being chosen because they're high risk. There's a lot of worry in theatre, both from all the teams. So I can't give that a black and white question, but if I could just talk a little bit more about the sort of training implications, if you want me to, Duncan.
Yeah, sure.
I think it's a really important issue. The training bodies are aware of this, and they are aware of the deficits that's going to happen. They are proposing what's called an outcome 10 for trainees during the COVID time, so that if your ARCP comes up, don't worry about it. You'll be allowed to have an outcome 10, which means that they appreciate that you won't have hit your targets, you won't have done everything you were supposed to. You can use it to extend your training, but you don't have to. If you're earlier on in your training and you're hitting your targets, it's not necessary. So not to be concerned about that. I think as consultants, we have to learn to be a lot more creative to train our trainees. There's going to be a lot more emphasis on CBDs. Rather than indicative numbers. The indicative numbers are going to drop, particularly in our speciality in FNUU. But I think that we just have to manage things better. The other sort of thoughts I've had about this is we'd love to move more towards simulation, but simulation has got significant implications during the COVID era with things like social distancing. So I think we're all going to have to take that on board and see what we can offer the trainees. And also, just to mention that this isn't an altogether negative thing. To learn to be in a difficult situation, a lot of our trainees have gone into COVID wards, have gone into critical care, and they've been absolutely fantastic. Certainly that's what we've seen. And also to encourage the trainees to use these opportunities to be involved in reintroducing the services. We as panelists know firsthand how difficult that is, and to plan those procedures and get your trainees involved in that.
It is a terrible sort of situation we're in, but we should take the positives from it. And I think it's fantastic that we have very closely to our side the section of trainees as part of an integral part of BAUS. So I think together we'll come up with a solution with the SAC and the various authorities. Ben, a little bit more prosaic. When can we safely restart BCG treatment for high-grade non-muscle invasive bladder cancer?
I think we can start that now in the right situation in selected patients. We're all very biased, I think, Duncan, clearly by what we've seen in our own hospitals and on the ground. You know, we've had more COVID patients at Guy's or St Thomas than anywhere else in the country. We had 150 in ITU. That was 6 weeks ago. We don't have that now. We had 24 cases in London on one day last week. So we are well down that curve. And the risk of bladder cancer progression is so significant that I think that we are in a stage locally to recommend restarting that, and we have done.
Yeah. Okay. That's good. There's many questions about rationale, about regimens and maintenance against induction, but I think we'll probably get you to answer those, or the section to answer those individually if people identify who they are after this seminar, webinar. So I want to come to Madge now. So something close to my own heart and a bit of a heart sink is that there's a lot of people in the NHS, certainly in the female section and probably in the andrology section, you have chronic pelvic pain syndrome, and they seem to have disappeared. so does that sort of affect how we might sort of regard them in the future, how we might treat them, whether urology should be part of their treatment? Certainly for the prostatitis and the male pelvic pain. What's your views on that?
You know, it's a very interesting thing, Duncan. It's amazing how a pandemic can put things into perspective for some people. I mean, I had a patient who was desperate for some form of surgical outcome for his chronic testicular pain. And I did a telephone consult this week from home, and he just said, look, I totally understand, don't worry about it. I can live with it now for another 6 months, having been one of those guys who was very incessant about having something done yesterday. So it's you know, it has put people's mind into perspective. It has changed the parameters of what they're looking to have as an outcome. It's made people prioritize aspects of life much more than other elements of their pain. But I think wholeheartedly across much of the other specialties, people have seen a downturn in the number of chronic pelvic pain patients coming in. Having said that, there has been a downturn in lots of different people presenting for lots of different medical problems across the entire field of medicine. So there are some people who are staying away with a fear that they cannot contact people or cannot get back to normal services. So we can't totally ignore them, and we may start seeing more of them coming out of the woodwork now. So definitely an interesting phenomenon, but I think they are all still waiting there. And I think there's something on the Royal College website where it talks about the hidden waiting list. You know, the patients who are waiting in the wings, who haven't raised their heads again to say, look, I need help. And I think we may start to see them coming back in the next couple of weeks.
This one's probably, this is not thought about before, but it's probably from Darren, actually, from Rachel Morrison. Does BAUS think that MRI scanning carries a particular risk of spreading COVID due to the enclosed nature of the scanner? My trust seems particularly worried about this. You got anything to think about that and say about imaging, Darren?
We don't do many MRIs in stone surgery.
No,
I can't. I guess you would have to be slightly cautious if you'd got a patient who said that they were particularly claustrophobic and therefore might have a whole coughing and spluttering fit whilst they were in the scanner. I wondered whether it was going to be, super esoteric about the effect of a high-powered magnet on COVID particles. Maybe we'll see that written up in the New England Journal by tomorrow afternoon. I don't know, but that's one of the questions that we could happily take back to our magnificent radiological colleagues and get you a better answer.
Ben, as somebody probably use a bit more MRI, have you got any experience of that? As people sort of reducing your access to MRIs or slowing things down in patients?
Well, the original document sort of said, right, we're not going to do any CTs, we're not going to do any MRIs, CTs are all going to be used for the chest. I mean, we've almost got radiologists at the moment fighting over chest x-rays to report because we've got such a big group of radiologists that actually the footfall for prostate MRI is only about a third of what it normally is. Apparently they clean it and they have to have a downtime of 1 or 2 hours, so you can only do about half as many per day. And I would, like with Darren, I would think that if you questionnaire the patients well and beforehand, and they're not symptomatic, and then you iodine swab them all down, which they are, that actually we haven't had any pushback. And I think we've been using certain MRI scanners for the elective 2-week waits and other certain ones for the inpatients to try and have a sort of a green and a red stream within the trust.
Okay. There's quite a bit of concern out there about diathermy smoke in open operations, causing perhaps transmitting COVID. And I certainly know that there were concerns about it being HIV, Hep B being found in diathermy smoke. So those of us who do open operations, do you always use smoke scavengers? Madge, what about you?
So yeah, not routinely in the past, but I have to say it's something I would strongly consider in the future. I mean, certainly doing things like urethroplasty, where your face is pushed up against the perineum and you're using diathermy for dissection. The plume is going directly into your face. I have to say, I think for the future, we are going to have to think about using technologies to make sure we reduce that plume even more strictly than before.
Yeah. And of course, that was one of the concerns, wasn't it, about the high pressure smoke plume from laparoscopic surgery, especially if bowels involved. But of course, with the excellent sort of document that Tim O'Brien and his colleagues put together on that set, it looks as if really the risk in urological laparoscopy is not quite as significant as in general laparoscopic surgery. Lots of good answers, lots of good questions coming through. Let's take a few more. There was something about here. This is quite interesting. We've got a colleague from Sri Lanka, Satish. Hello, good evening, or good morning. Any strategies have been planned to clear the backlog of cases that come out of the COVID-19 pandemic? We're currently working on methodologies here in Sri Lanka. Well, to be fair, what we're talking about today is an idea to try and clear the backlog, but I think it's going to be very difficult. I think theatre lists will probably get through about 50% of the work that we've used to enjoy. I think when the pandemic becomes slightly easier, I think our anaesthetic colleagues will probably want a bit more of a rest because they've been taking the lion's share of looking after these sick patients. I don't think, certainly in our National Health Service, there's going to be an easy return back to normal. And I know that because we work closely with the FSSA, the Federation of Surgical Specialties, and I think that's a view common to most surgical specialities, that the new normal is not going to be normal for a very long time, without being too pessimistic. So this is all about that, and there are many things that we can do towards it. Okay, a few more questions here. One current question, which I think is very pertinent, is from what guidance does BAUS have on surgeons or healthcare staff from Black and ethnic minority backgrounds? Should this be addressed in terms of increased risk factor, COVID, staff testing, PPE, etc.? So does anybody want to speak to that? I've got a view, and just to say that BAUS will be producing a statement about the vulnerable, including BAME personnel, in the next couple of days, actually, because there's lots of risks associated, but obviously that's the most evident. And if you look at the national newspapers and the faces of the people who've succumbed, it's frightening. Does anybody want to talk to that amongst the panel?
No.
No. Okay, so it is being addressed. We're not ignoring
One for the president.
Not ignoring it. It is a big issue. We need to try and mitigate. I think the answer will probably be individual risk stratification. So there is a colleague of mine in Leicester from primary care, Professor Cunty, who is basically done a risk stratification tool for ethnic background, age, comorbidities, etc. And every person will be able to go to an occupational health risk assessment and decide their level of comfort in what they do in terms of the jobs they do, how they do them, what protection they have, what they're comfortable with. I think the overarching comment by Derek Alderson, the President of the Royal College of Surgeons of England, sorry to mention that in this forum, is that if you don't feel comfortable being asked to do something, you don't feel you got the right degree of protection, whatever your reasons, you shouldn't do it. You should say no, you should stop, and you should seek advice. And I think BAUS would wholeheartedly support that, and we have done so. So don't feel pressurised into doing something you feel inadequately protected to do. And that goes right across the board. So I hope that sort of hopefully answers that question. Now then, any more questions? Michael Palmer. Thank you, Michael. Good evening. What prospects do the panel feel there are for the return of post-cystectomy reconstruction in the medium term?
Well, it's reconstruction and oncology. I mean, I would feel that, I think, Duncan, you've clearly said that everyone needs to frame their own decisions a little bit around what's happening within their region and know their numbers. We were very scared at first of doing cystectomy locally. We've had a couple of colleagues from other specialties who had a patient die, and 2 in ITU, having done GAs for big cancers under COVID from thoracics and ENT, and we were worried. We've now done 400 cases within the cold site, and we've not had any further problems with 2 weeks of isolation and admission and a swab. So I think we're now at the stage where if that's deemed to be the most appropriate thing for the patient, that we would move on to that. But we would not have done that 6 weeks ago. So that would be, I think all of these things are now evolving, and everybody's in a different place sort of around the country. But I think for people who are sort of halfway down the downslope, and of course we don't know that, it might take 3 years, but we're going to get back to doing that.
Yeah, I think that's a very sensible thing. There's a comment really here rather than a question. Mrs. Randa Dickinson in Plymouth, the most interesting observation of this crisis is a variation in regions, if not units. That's certainly true. Plymouth have carried relatively normal with ureteroscopy and perks and robotic prostates being performed. Our trainees have remained doing urology with no change in rotas. I think a review of our experiences post-COVID-19 will be enlightening. I think COVID is here to stay. I'd agree wholeheartedly with that, Dickie, and I think in BAUS in November 2019 there will be some COVID sessions, and I think sharing what's happened throughout the national picture, which is very variable, is very interesting. We're fortunate to have a regular trustees Zoom meeting, and up in Newcastle it's more or less business as normal. You guys in London have been through the mill and had a terrible, torrid time. So it's very variable throughout the country and a different sort of timescale. So I think we will look at that. And in fact, I'm meeting with the regional reps on Wednesday, and we're going to discuss just those sorts of issues. So thank you for that comment. Okay. Anonymous attendee, transurethral resection or any cystoscopic diathermy typically produces a plume of smoke or fumes which one can often smell after removing the scope. Should all such procedures be done with an FFP3 mask? Who wants to answer that one? Sheila.
I think the reason nobody wants to answer that question is because there's not a right answer. You've got to, all trusts have very strict protocols for what you can and can't do. So, there isn't a right or wrong answer for that question. Our trust is not insisting on that for TURBTs. Obviously, there are other reasons to use an FFP3 mask, but not specifically for that. And particularly if the patient is under spinal anaesthetic.
Okay.
Can I make a comment that's not directly related to the question, but it sort of is to the answer? In that at the peak of the surge, as I've alluded to before, the amount of information that came and the number of different sources was unmanageable, and every document that you opened contained a whole series of links to other documents, and when you opened them, not only did they have other links to other documents, but most of the things that you read either contradicted to a small degree or absolutely totally what you'd already seen in the previous stuff. And then, of course, you don't know whether things are being changed because the evidences have changed or simply the availability of it has. And this was like throwing petrol on a fire to increase the amount of uncertainty, anxiety, and made the whole situation, I think, a fair amount worse. What we need for this next phase, and it's brilliant that BAUS and the College of Surgeons in Edinburgh have put this together to do it, is one central truth. Which everybody can go, well, those are the facts as best we know them, and then with openness and clarity can interpret them to suit their own patients, their own environment, etc., etc. It would make life a whole lot easier doing it in that direction rather than trying to piece it together for ourselves from different sources. So hopefully to some extent we've achieved that with what's on the BAUS website and what we're all up to here tonight.
I would totally agree with that. Okay, I've just got a comment which is very useful. Mr. Nambirajan has said the Royal College of Radiologists has not given any caution against MRI. So there we go. So learnt something as non-radiologists, but I think they are. It is everything else is taking slower, taking a lot longer to sort out. Okay, this is one I think is common to everybody. James Donaldson from Aberdeen. What are the panel's thoughts on preoperative screening for asymptomatic patients prior to surgery, e.g. throat swab, CT chest? Is sensitivity and timing logistics? Thanks. So I can answer that from my unit. We do a throat swab 48 hours beforehand, but realizing that there's about up to 30% false negative rate for large surgery, so nephrectomies and cystectomies, we do a CT chest on the morning of surgery, and if there are any changes, we will probably cancel unless there is absolutely crushing urgency to get that done. Does anybody have a different system for that?
We're the same, but we isolate for 14 days.
Yes, of course.
48-hour swab, yeah. And actually, I just want to point out with the swab has actually got much better, because I deal with a lot of disabled patients, and we've got volunteers that will go out and collect the swabs from patients' homes and bring them to the hospital. We've got a whole group going out now to get the swabs, which has been fantastic.
Mm-hmm.
Yeah, we would be the same in terms of 2 weeks isolation, Duncan. Admission beforehand for a swab that happens 24 hours before. Interestingly, they call you at least twice during that 2 weeks to check the patients are in. And if they answer the phone and they're down the shops or when they're in the park, then they're off, and they tell them that. So, but since we've gone to that, it's been much safer. Interestingly, we've not gone down the route of the CT chest.
Okay. Yeah. Okay. We've got a feedback on the diathermy issue. John McCabe said diathermy is not an aerosol generating procedure. No, we know that. One should also note, in addition, coronaviruses are very heat sensitive, hence would not survive diathermy, from his microbiologist. So that's quite reassuring, I guess. It'd be nice to get the microbiologist into your theatre and see if he wants to test that out. But that's good. Okay. Anything else we've got? Okay.
Communicating with FFP in theatre. Any tips?
Yes. Tricky, isn't it? I don't know. I've tried a variety of FFP3 masks, and they all seem to have various pros and cons. The paper ones, or the softer ones, seem to be easier to communicate with, but perhaps not provide enough protection. The Drager hood I've used with a ventilated hood, that's very comfortable inside, but it really is quite difficult to speak because they're quite noisy inside a fishbowl. Anybody else's preference? I mean, in theatres we use a walkie-talkie system, so the theatre runner has one walkie-talkie inside, and the person outside has the other walkie-talkie. So if you need kit brought into theatre, it's very clearly done. So that's quite a useful, rather than writing on a Chinograph pencil and sticking it up to the window of the theatre. Ben.
I was just adding to that I think that I'm very interested in non-technical skills and the elements of training, and this is a really important issue. It's very dangerous. The other day, the timeout happened. I didn't even know it had happened because it was a muffled person, who was too far away for me to really hear anything. And so it's vital, I think, when we're setting up cold sites, that surgeons work with anaesthetists that they're familiar with, doing procedures that they're familiar with, and that actually that element of team has actually saved us, I think, on a number of occasions. And we've tried to pair up with people that we know, doing things that we know. And you don't have 200-300 cases with the same person. You know how each other works. And to an element of that is perhaps doing as much as you can in the briefing beforehand, rather than trying to go through it too assiduously during the muffled timeout.
Yeah.
I was going to say very similar things, that it's, and we've seen one of the questions from one of our international friends about, what are going to be the positives to take from this for the future. And this, is a really good way of highlighting the essential need for a team of people that are used to working with each other more of the time. It's way easier, as Ben's just alluded. If you're working with a regular anaesthetist, you can communicate, with a raised eyebrow under the C-arm for if you're an endourologist. So that having a team of people who know, because it is noisy, you can't hear, they can't hear you. Actually breathing in and out for an hour is a bit of a struggle without trying to raise your voice, and keeping the communications short and sweet, and having a really good debrief afterwards where you can say, well, this is how to do it next time. But the bottom line is you need a team of people who are doing it, and that is going to be one of our pressure points as we reintroduce more work. We won't always be working with people that we know over years.
Yeah, very, very, very good points. Darren Moyer, I've just had 3 or 4 same questions. Is laser stone surgery aerosol generating?
Not in my theatre. Well, we've had this one across Twitter. And of course, if you've got the laser in the scope and the scope in the ureter or in the kidney, then it is underwater. So when we had this exchange on Twitter, the distinctions, which will not mean anything to the rest of the panel, but whether you're a duster or a fragmenter might make a difference, and it might make a difference for those people who will get hold of a thulium fibre laser first. But I think if it's all taking place underwater, the bubbles have evaporated, then I don't think so. But like we had about the urine question earlier on, of course you want to avoid splash. I think you're much more likely to splash urine when you take the scope out, or if you take a basket or a laser fibre out of the scope quickly. Yet another example of good communication with your team and working with people that you know well, if you can.
Okay. Well, I think that's been a fantastically valuable session so far. There are hundreds more questions which we could. I think we've addressed the major issues. If there is anything that people out there feel we haven't discussed, we'll try and get back to you with answers of specific questions. If there is any broad sweeps of topics we haven't discussed, please do let us know, and then we may run another one of these seminars, another webinar answering those specific issues. I'd like to thank all the panellists and the Royal College of Surgeons of Edinburgh for hosting this again, and for all your very good questions and interaction. Before we close, I'm just going to go and put my panellists on the spot and ask each one for a single take-home message before they say goodnight to you. We'll start with my top left, that's Sheila. What's your take-home message before you sign off?
My take-home message is I think just what a great sort of group of people we are. I think my committee's been fantastic. We were asked to pull together things very quickly. And I think everybody's had that experience, and I'm very grateful. Okay,
great. Madge, you're next in the line of fire.
Yeah, so I was going to quote something from Jonathan Glass, one of my great colleagues at Guy's Hospital, who said, in this era we're trying to build a boat and sail on it at the same time. And so you don't really know what's going to lie ahead, and it's a difficult path of what we're doing at the moment. But I thought that quote really does summarize what we're trying to do at the moment. Everything we're doing is guidance, and what's true for now may not be true for down the line. But as long as we have a coherent, sensible voice coming through from BAUS, we can guide people, with one voice.
Okay. Ben, you're next.
Yeah, well, you've caught us with that, Duncan. Relating to the questions, I'm very happy to answer any of the oncological ones, disseminate them amongst the committee. I think there is a lot of talking point about some of the things like lymph node dissection, non-muscle invasive bladder cancer, and I don't, again, reiterate, these are not hard and fast rules. If you think it's right for your patient, then do it. And we are a great team. I'm really grateful to BAUS, and I would just say from an oncology point of view, we need to stay passionate for our patients. We're representing our patients, and we need to do everything we can to optimize their care. And we are going to have some hard times ahead. The anaesthetists have been, really under the cosh. Some of my colleagues have been amazing. I mean, proning people, central lines, all of this, we've avoided that. I've done a few big nephrectomies, and we're ready to go, and we're going to work some weekends. We're going to do some extra work, and we're going to get people sorted. And I think we all need to just, dig in and look after our patients.
Great, good message. Darren.
Well, we've never done this before. So as we've heard, there's a lot of work that we've had to postpone, and it all needs to be reintroduced. All of the patients are going to think that their case is most important, and their caring surgeon is also going to think that their case is the most important. So there's a lot of work to do. There's not a lot of space. And the people that have been doing all of the work so far are understandably quite tired. So the most important currency is kindness. Be nice to each other, be supportive, be understanding. How can I help you today? And are you feeling okay? And I'm going to make it my strapline for all of this. We're all still in this together.
Great messages. I think those are fantastic messages. I would just like to, on a practical note, know that we've got a lot of people from Pakistan, Sri Lanka, the Middle East, all joining in. If you want access to any of these documents and you're not a member of BAUS, you're more than welcome. Just email admin@BAUS and we can give you the PDFs of all these guidelines. They're constantly updated. It's a privilege and a pleasure to sort of try and bring all this together. Keep yourself safe. Like Darren and everybody says, be nice to each other. We are good in urology, and on the whole, we are pretty nice to each other. Keep doing that. And these plans to upscale can always be, the brakes can always be put on. If we're using too much PPE, if people get a second spike, people get ill, wind it back down again. It's just a variable feast. It's not just a direction in one direction. It can be put down as well as up, and we can go back to the original guidance if we need to. Heaven forbid we need to do that, but if we need to do that, we should do that. So, okay, everybody, I'm going to say good night. It's just 6 minutes over time. Thank you for everybody. Thanks for all the comments. We'll try and get back to as many specific comments as we can in the next few days. And if the feedback's good, we'll have another one in the near future. Okay, take care, guys.
Thanks, Duncan.
Thanks.
Thanks,
Bye.
Duncan.
Bye. Bye.